to take a look here at chronic obstructive pulmonary disease. So we'll get started on that by taking a look here at the patho. So primarily, chronic obstructive pulmonary disease, or COPD, is a condition that could present in a few different ways. It may present primarily as emphysema, or it could present primarily as chronic bronchitis, or it could also present, and probably more commonly presents, as kind of an overlap syndrome of a patient that has emphysema and chronic bronchitis type changes. So the emphysema type patient has decreased lung elasticity, so their lungs just kind of get stretched out, and then they don't recoil properly as they should to help get rid of CO2 when we're having gas exchange. And then we have chronic bronchitis, which is chronic inflammation, and this causes increased secretions. So these patients develop like a really cough that has a lot of really thick mucus. And the highest risk factor for developing COPD is smoking cigarettes. And this is because, smoking cigarettes paralyzes the cilia, and so that just really affects the ability of the lungs to, get waste and mucus and things like that out of the lungs. And also patients who have a history of asthma, they have an increased incidence of developing COPD. And then the other thing is a genetic predisposition, and that is an alpha-1 antitrypsin deficiency. And these patients will primarily develop emphysema. And, you really need to be concerned about that if a patient develops emphysema at a young age, like in their 20s, and doesn't really have a strong history of cigarette smoking. They could have a strong history of cigarette smoking, but especially if they don't, it's like, well, we don't have any reason that this has really occurred, so we need to be thinking about other reasons why this may have occurred. So when we discuss COPD, we usually try to kind of just like characterize the patients as a chronic bronchitis patient or a emphysema patient. And to do that, this is just kind of like a depiction that's been used for years to just, give us an idea of what these patients actually look like. So we'll start out here by looking at the blue bloater. So this is typically the chronic bronchitis type of presentation. So with the bronchitis, it affects the bronchi, so the larger airways, rather than the alveoli, which are the little grapes, at the bottom of the lungs, on the, outermost portions. So this primarily affects the larger airways, and it causes a chronic productive cough. So lots of thick mucus that interferes with gas exchange. And their PaO2, so their blood oxygen levels are decreased, and their arterial CO2 levels are increased. And they commonly will have some cyanosis appearance to them, and so this is kind of where the blue of the blue bloater comes in. And they commonly have obesity, so that's the other factor there, is the bloater, the obesity. And then kind of on the other end of the spectrum, if we think of this as a spectrum, we have the pink puffer, who's the emphysema patient. And these patients are cachectic, and so they have cachexia. And if you don't know what cachexia is, it is just like an extreme form of malnutrition where the patient is just so skinny. You might think of them as being like emaciated. So they are spending all of their energy to just breathe, so they lose weight pretty quickly, and that's a sign that we're maybe moving over into like advanced emphysema when our patient starts to become cachectic. And you may have heard like advanced AIDS patients may have been referred to as cachectic. That's another category of patients that we might refer to as cachectic. These patients typically have pink skin. They have accessory muscle use, so they are really working hard to breathe. They have diminished breath sounds. They have an increased respiratory rate. And so these are things that we might just see at rest. They have air hunger. They're ready to start inhaling before they're even done exhaling. Carbon dioxide is produced faster than it's eliminated, so they have carbon dioxide retention and chronic respiratory acidosis. So this patient as well is going to have a PaO2 that's decreased, as well as a PaCO2 that's increased. The patients have hyperinflation, so their lungs kind of become larger than what they should be, and that causes the patient to have like a barrel chest, which we'll talk about that more in a moment. They have air trapping, so they hang on to this air, and it reduces the elastic recoil of the lungs, causes the alveoli to become enlarged and be destroyed, so then there's less surface area for gas exchange to occur. And these patients can also develop bullae, which is where they kind of have like a blowout area of the lungs, and this can cause problems. They can actually rupture and lead to a pneumothorax as well. And then alpha-1 antitrypsin deficiency, and this is an enzyme that's normally present in the lungs, and if it's not present in the lungs, it can cause some problems with breathing and lead to emphysema, and it's genetic. Okay, that is our patho there. So let's move on over here to assessment. So again, with this disease process, we need to be cognizant of things that are expected findings. So if we have, certain expected findings, we're not going to get excited about those because those are like the normal things that happen to patients who have COPD. But then there's going to be some other findings that it's going to, if they're asking you a priority question, which patients should you see first? There's certain things we're looking for there that are signs of respiratory distress, especially in these patients. So shortness of breath, they may have chronic shortness of breath, okay? So they may just always kind of appear short of breath. A lot of them are going to have a chronic cough with sputum production. They may have a flattened diaphragm, which leads to decreased chest wall expansion. So, the diaphragm sits at the bottom of our lungs, and when we inhale, this kind of opens up and then it closes back up when we exhale. So if it's always like this, breathing in, it might move a little. Breathing out, it's not going to move, like it should. So we have this retention of CO2 and air trapping, and our chest doesn't expand like it should. But because we have this air trapping, we have a barrel chest. And so that's a chronic finding. That's not a reason to rush into the patient's room. It's just an expansion of the chest. The chest is larger than the average person. That's really common with COPD. And if you've taken care of COPD patients, or when you start taking care of COPD patients, you're going to see that and you're going to recognize it and you're going to be, used to seeing that because it's a very common finding. These patients may have wheezing. Things you do need to look out for is like tripod positioning. If your patient is tripod positioning, that means they're kind of like leaned forward and may have their elbows on their bedside table kind of leaned over, or they may have their elbows on their knees kind of leaned forward, kind of putting themselves in like a triangle position, and that's a sign of respiratory distress. If you have a patient that has tripod positioning and they're having like retractions, kind of like where they're really using those accessory muscles, that might be a picture of a patient that's in respiratory distress. And weight loss. They are, as their disease advances, they're likely going to have weight loss. If they're more of the blue bloater, they might not, but they may have weight loss, especially if they're more of the emphysema type patient. All right, some tests that we do. ABGs. So this just kind of gives us a really good overall picture of their respiratory status. So it's common that they're going to have CO2 retention. So their arterial CO2 levels are going to be high, and their pH level is going to be low, and they're commonly going to have a low arterial oxygen level as well. You may find that they will have polycythemia, which is a fancy word for an increased amount of red blood cells. So their hemoglobin and their hematocrit are likely going to be high on their CBC. So, you might expect it to be 13, 14, but it may really be 16, 17, 18 in some of these patients. And if you think about why that happens, it's because, we have a chronic low oxygen situation. So the body is trying to compensate for that by making more red blood cells, because hemoglobin is what carries oxygen. So if we have more hemoglobin, our body's hoping that this will help us have an increased oxygen. So if your patient has increased hemoglobin hematocrit, and that's kind of like a chronic problem for them with their COPD, that's a sign that they have just chronic low oxygen status. Chest x-ray, they'll have hyperinflation. So like we said, their diaphragm is going to be kind of flatter. So, on a chest x-ray, we're used to seeing kind of like these dome shapes on the diaphragm. But if you find a patient that has COPD and you get a chance to look at their x-ray, you're going to see kind of more flattened out diaphragm, and the lungs usually look really long. The black area where the air is, it usually looks really long. And we do chest x-rays also to rule out infection, because these patients commonly will get infection. Especially the patients that have the really thick mucus, things like to grow in places that are warm, dark, and moist. So if I have a lot of mucus sitting in there, I'm a lot more likely to get infection. So chest x-ray can help rule that out. Patients will also have pulmonary function testing, which is a series of tests that the patient goes through, where they go into, usually like a respiratory department at a hospital or outpatient setting, and they have to do some breathing that's measured on, how much lung volume they have, that type of thing. And they might do that with and without a bronchodilator. So if they use the bronchodilator and it's improved, that just kind of gives them more information. And then oxygen saturation, that's another test they might have, the pulse oximetry that we put on, and that's an SpO2. And so patients with COPD commonly are like 88, 89. Usually our goal for them is 88 to 92. And so the reason for that is patients who have normal respiratory function, so like myself, I am triggered to breathe because I have a chemoreceptor in my blood that is looking for CO2. So when my CO2 level gets a little bit high, just a fraction high, my body says, breathe. Well, in these patients who have COPD, they have chronic increased CO2 levels. So those chemoreceptors that are looking for the CO2 are constantly oversaturated. So they're always full of CO2, so they don't really get excited and tell the patient, oh, you need to breathe, when their CO2 gets high, because it's always high. So these patients, the COPD patients, they typically are stimulated to breathe because they get a low oxygen level. Okay, so we tolerate a little bit lower oxygen level in those patients. So we don't want to, give them way too much oxygen, because we think maybe that might knock out their respiratory drive, is what we would call that, where they just aren't stimulated to breathe if they have too much circulating oxygen. So we just are careful with oxygen with these patients. If they're 88, yeah, we could put some oxygen on them and bring them up to 92. But we don't need our COPD patients to be 99% on oxygen. So, okay. Moving along here to interventions. So positioning, a quick and easy thing that you can do for your patient is elevate the head of the bed. So this is going to help with increasing the chest expansion, allow for the diaphragm to expand as much as it can. So this is a quick, easy, do it, get it done. And then we kind of look at some medications here. Beta-2 agonists, so we'll talk more about that down below. Anticholinergics, corticosteroids, mucolytics such as guaifenesin, or you may have heard it called Mucinex. And then oxygen, these patients may need to have oxygen as an intervention. They may need to have non-invasive inhalation, such as BiPAP or CPAP. Respiratory therapy, so pulmonary rehab, where they can go to a respiratory department or pulmonary rehab department, and a respiratory therapist can help them do exercises to build up their lung function. And then some of these patients may have to have surgery. This is a really advanced situation, but they may have to have lung volume reduction, where they kind of take out part of the lung so that it can expand more, since I said it's like, expanding too much, taking up too much space. And then they may even need to have a lung transplant. Okay, so we're going to talk about these interventions a little bit more in detail. So the beta-2 agonist, this is a bronchodilator. Okay, so you think about the bronchioles, your, airway, and then dilator. So it opens up the airway. So when you see beta-2 agonist, such as albuterol, I want you to think that opens the airway. Okay, and this is a sympathomimetic. Okay, sympathomimetic. And this stimulates beta receptors. And beta receptors are the thing that stimulates like the sympathetic nervous system. So when a bear is chasing me, my sympathetic nervous system is stimulated, and this causes me to have an increased heart rate, my lungs open up, and I can go. I'm ready to go. So beta 2 agonist stimulates the sympathetic nervous system. So my patient who's having a sympathomimetic, such as albuterol, they might have an increase in their heart rate. We hope they're going to have their lungs open up, because that's the whole point of giving it. And then the other thing is they might develop tremors, because it really does stimulate that sympathetic nervous system, so it might get them just a little anxious and shaky. So those are common side effects. And so we have short acting, which we use for acute symptoms. So this is a rescue inhaler, albuterol. Okay, it comes as an inhaler, like a meter dose inhaler. Also comes as a nebulized medication that you know, the liquid, the little bullets, and you put that in the nebulizer, and then they inhale it that way. And then we also have long-acting beta 2 agonists, and these are used as a controller drug. So these kind of help me to not have an exacerbation of my COPD. So I'm take this every day, and it's not going to help me when I'm in an acute situation. If I'm having like a significant, exacerbation, this isn't going to fix it right now. I'm still going to take it because it's my daily medication, but it's not a rescue inhaler. And those end in meterol. So salmeterol and formoterol, those are two common ones. And then we have anticholinergics. They're also called antimuscarinics, if you've heard it called that. But they basically dry up mucus, so they just cause that stuff to get drier so that it's not so thick and causing me to cough so much. And the common one that we see is ipratropium. There's also tiotropium. This one's the nebulized medication. Tiotropium is an inhaler. And then we have corticosteroids, and we have these as inhaled, and then we also have them as oral and IV preparations. So betamethasone, prednisone, methylprednisolone, these are common forms. Betamethasone, that's an inhaled steroid. Prednisone is an oral steroid. Methylprednisolone is an IV steroid. And I always tell my students, this is the one. So if you have a question on a test, which inhaler do you rinse your mouth out after use? It's the one that ends in 1. Betamethasone, that's the one. Because if we are using steroids, we're at increased risk of getting thrush. Okay, so we have to rinse our mouth out after we use betamethasone or an inhaled steroid. Mucolytics, so we said guaifenesin or Mucinex. This helps to thin secretions. It lyses the mucus, so it breaks down the mucus. But you do have to drink lots of water for these to work. Oxygen, we want to keep our patient's saturation greater than 92%. If they have COPD, like I said, we don't want to give them too much oxygen. I said the breathing was stimulated by increased levels of CO2 in the normal patient, but given the chronic CO2 retention in COPD patients, low oxygen stimulates breathing, and we don't want to knock out their respiratory drive, so we're not going to give them too much oxygen. Now, we don't want to withhold oxygen, and if they need oxygen, we're going to give it to them, but we just don't usually give them a ton of oxygen. And then non-invasive ventilation, positive pressure. This pressurizes the air to a higher pressure than room air, so it makes it easier for the COPD patients to breathe in oxygen and breathe out carbon dioxide. And sometimes it's used with high levels of CO2. So if the patient's CO2 levels are increasing, we put them on the BiPAP, and that helps to improve that. Okay, E for extreme. So, extreme things. So, cor pulmonale. Okay, this is right-sided heart failure. And this is caused because the increased lung volumes make the right side of the heart work harder to pump the blood into the lungs. So they're constantly having to work hard to move that blood through the pulmonary artery into the lungs, and it causes this muscle to have to really work, and so it develops heart failure. Okay? And in right-sided heart failure, we typically see symptoms that are like swelling and edema, we see peripheral edema. So edema in the legs, we might have backup of fluid into the, belly, and then we see jugular venous distension. So those are signs of right-sided heart failure in our patients who have COPD. And then hypercapnic respiratory failure. So when our CO2 levels get too high, this can cause our patient to have decreased responsiveness, and they can have what's called, they can be obtunded, where they just are like minimally responsive. And this leads to like decreased respiratory drive, and it can really be serious. And so these patients usually end up getting put on BiPAP. They may also have to be intubated if it's really serious. And then just keep in mind, absent lung sounds could indicate serious airflow obstruction or pneumothorax due to blebs, like I talked about earlier. So if you hear wheezes, okay, that means they're wheezing. I mean, they're restricted a little, but they're wheezing. But if they're wheezing, and then all of a sudden you're not hearing anything, they may have some serious obstruction. They could have a pneumothorax as well, which is just air that gets into the lung space where it is not supposed to be. Serious problem. Okay, nursing diagnosis. Well, the obvious one here is impaired gas exchange, okay? And then weight loss due to increased respiratory effort in our pink puffers. Anxiety. If you cannot breathe, you are likely to be anxious. So these patients oftentimes have a big problem with anxiety. And so then, we want to treat their anxiety, but some of the anxiety medications can cause a decreased respiratory drive, so we just really have to be careful with that. We have to be careful. And like I said, these patients are at increased risk for pneumonia because they have that, lots of mucus in there, and it's a warm, moist, dark place, and things like to grow. And then ineffective airway clearance due to thick secretions. So just keep in mind, gas exchange occurs at the alveoli. Okay, so when we have emphysema, we have problems with our alveoli losing their elasticity, that can cause impaired gas exchange. And then ineffective airway clearance is like something that happens like in the bigger airways. Like maybe I get some thick mucus in there and I just cannot cough it up, and I'm just trying, but I just have, like a mucus plug or something like that. That's an ineffective airway clearance. It's a little bit different than impaired gas exchange. Teaching. Okay, we are going to try everything we can to get these patients to quit smoking. And, most patients who have been diagnosed with COPD have been told, you could die. You could die if you don't quit smoking, because COPD is a leading cause of death in the United States. But a lot of them continue to smoke because smoking is highly, highly addictive. Okay. So we're going to do what we can to try to get these patients to quit smoking. As long as they're smoking, they're going to just have a steady, probably decline kind of in their lung function. But if we can get them to quit smoking, their lung function probably isn't going to improve, but it might level off to where now it's not declining, but it's just kind of like leveled off. We want them to get vaccinated for pneumonia, influenza, and COVID-19. We already said they're at high risk for pneumonia just because of all the mucus. One of the most common complications of the flu is pneumonia, so if we can keep them from getting the flu. And then, of course, COVID-19 is a real threat to patients with underlying lung disease. And we want them to avoid crowds and perform good hand washing, all the normal measures we would take for patients that we want to avoid getting an infection. And then there's diaphragmatic breathing and pursed lip breathing, which just basically helps the patient to kind of blow off some of that CO2. It's a common thing that we'll see in COPD patients. And we want them to have a high-calorie, high-protein diet with foods that are easy to chew. So protein is going to give them energy a lot longer than something like carbohydrates. So mashed potatoes, high carbohydrates, soft, easy to eat, but they're not really providing that much like ongoing nutrition for the patient. So a lot of times we'll use like protein shakes and things like that because they really get tired when they're trying to eat. We also recommend that they don't drink like a ton of fluid while they're trying to eat. We'd rather them fill up their belly with food and then they can drink later. And they should drink. I mean, we want them to drink because, not having enough liquid in your body leads to the secretions being a little bit thicker. So we want them to drink, maybe just not in the middle of trying to eat. And then energy conservation. So they need to, have periods of rest and that type of thing, because they do get really worn out just a lot of times just from breathing. So that's what I had to share about COPD. So I hope everybody learned something. Thank you.